Dr. Pines, Director of Innovation from USACS, will be speaking. I'll let you take it away.
Great, thanks so much. And thank you very much to Andrew for taking the baton with Urgent Matters. I ran Urgent Matters for 8 years when I was at faculty at GW. Now I'm at USACS. I'm National Director of Clinical Innovation, also a professor at Drexel University. So a few disclosures. Still work at USACS now primarily. Still do a fair bit of research and also do some direct innovation. I've helped co-found a startup company a few years ago called Patient Insight. So now we're going to talk about something a little bit different here. So here we're going to just describe some of the evolving role of emergency care in the context of population health and payment reform, and then sort of use that as a lens through which to look at the concept of injury prevention and sort of, more broadly, how do we actually get clinicians to really care about it in the emergency department setting? Because what I think we've heard a lot about is, how to impact it from outside the emergency department, research through big data sets, through public policy, and through advocacy. But how do we actually get to our everyday emergency physicians, physician assistants, nurse practitioners to really care about this stuff? And I think it's a challenge, but I'm going to talk about some of the ways we can potentially do that. So the role of emergency departments has evolved over the last 10 to 20 years. There are certain things that we do, so life-saving, time-sensitive care for things like MI, stroke, trauma. We're a 24/7 diagnostic center. We're clearly the front door of the hospital, and I think treated as so by our hospital colleagues. We're the safety net. Back in the 80s, EMTALA was passed. Now we are required to see everyone regardless of whether they can pay, so we have been the come one, come all site for care. We are a focus of disaster management, and also sort of non-medical issues show up on our door. So we have all these roles. So the question is, when it comes to population health, so 10 years ago, we were not really talking about the role of population health in the emergency department. So now we're sort of moving into this, public health role with more folks who are emergency physicians doing research in this topic, folks who are emergency physicians taking leadership roles. And it was interesting. So the 2002 SAM Consensus Conference was a conference about the role of public health in the emergency department. So this 2002, I was a second-year resident at the time. Didn't attend the conference, but I have read a lot of the papers, and it was fascinating. There were sort of two separate groups coming together. One that said, we should be doing all this public health stuff in the emergency department, and another group saying, wait, we've got all this other stuff to do. How do we add public health to the 25 things we're already doing? And I think that's a very real tension in the emergency department, is how do we do all this other stuff where we're already struggling to do our day jobs in a lot of ways? So the question is, what is really the role of emergency medicine? And clearly, one of the things we've seen over the last many years is the role of the emergency physician advocate. Folks are out there, on Twitter, on social media, writing articles about this, writing articles in the literature around gun violence. Figuring out how we can sort of reach outside the four walls of the emergency department and impact some of the social determinants of care that bring people in. And then finally, and I think really this is where the linchpin is here, we've become a much more active player in value-based care. So, over the last 15 years, there's been a much greater focus on cost and value, and I think a lot of that's coming to a head. And I think we can sort of use that lens through which to think a little bit about how we can think about public health, and a subset of that being injury prevention in the emergency department. So, a few critical questions. How do we use the resources of emergency departments for these novel purposes? So beyond the life-saving care and the social safety net, and specifically, how can the skills of emergency physicians be deployed in different ways? how can our knowledge be leveraged to advocate for our patients? And I think we do a pretty good job. We do a pretty good job of that. And then how does injury prevention fit into this? So this was a model that I did with Brendan several years ago, where we brought together stakeholders to develop a conceptual model of acute unscheduled care. So sort of what happens when people get sick and injured starting with social determinants of care, specifically looking at things like socio-environmental issues, public health issues, individual issues that lead to injury, and then what are some of the care decision-making resources that come into play, specifically community resources, individual resources, condition-specific needs, preferences, how people make setting choices. People may pick episodic settings like emergency departments, longitudinal settings, self-care, and then how we can measure quality. So I think this is sort of a good lens to think about when we think about where injury prevention and public health fits into emergency medicine. It really is about this upstream, these social determinants of care. It's the guns in the home, it's the homelessness, it's the people eating. People eating, trans fats and all the things that sort of produces illness and injury in our country. So when it comes to what we can do in the emergency department, so over the years I've seen a lot of programs for screening for a lot of different things. So GW, we've got HIV screening. Penn, we focused on hypertension screening. There's domestic violence screening. Now we do Ebola screening. It's interesting. Even as of about a year ago, a lot of the Ebola questions were still being asked at GW. Have you been to West Africa? Once people put questions in, they never leave. Suicide risk, guns in the home. So when you talk to public health folks, they say emergency departments treat vulnerable patients. And to not implement this intervention is a missed opportunity. Not to ask about this particular thing, whether it be hypertension, gun violence, whatever that is, it's a missed opportunity. Why don't you just ask about this? It's only one additional question. So if you look at the number of questions that are asked before people even see anyone at GW's emergency department, I looked at this about a year ago. It's about 20 different questions for everyone's "why don't you just ask about" question. So the concern is that this can lead to mission creep, and the question is, especially when you think about trying to implement this more broadly, is where are the resources to do this, and what is the incentive for an individual hospital organization to say, look, we're taking care of the MIs and strokes, trauma, we really do that well, and you want us to do all this other stuff, we just don't have the time to do that. Where are the resources, right? So this is a really big issue. Why, you sort of look at a lot of these programs here, and a lot of these are sort of end up being homegrown programs. So the HIV screening program was based on a grant from the DC government, and the funding went away, so the program went away. So how do you generalize that to the broader emergency care? This is the big issue with public health in the emergency department. So how do we deploy the knowledge of emergency physicians? And I think that we do a great job at this. You look on Twitter, you look on Slate, all these online magazines. People are, in emergency medicine do a fantastic job of becoming advocates for salient issues in emergency care. The This Is Our Lane movement is led by emergency physicians. We are directly trying to address the social determinants of care in an important way that is attempting to impact policy, funding for research, trying to impact legislation. We heard from Dr. Cunningham about a lot of the efforts to create funding for research and the politics of gun violence and why that may receive so much less funding than other types of areas, but how that's actually moving in the right direction. But these are emergency physicians who are leading this charge, because we see the patients who come in every day, and what really matters matters is the data, but also the power of narrative. So what I've found, especially talking to people who are in policy audiences, is they, showing them like big charts of data, this, and this. But if you can tell them stories, and we have the stories, that is a tremendously powerful narrative. And then tell those stories in public places. And a lot of our docs are, I think, doing a great job doing that. These online forums, social media. So Dr. Rani gave a nice TED talk about this. This is really how you sort of get it out there. But the question is, where are the resources for this? So a lot of this is based on the passion of individuals who really want to make a difference out there. But to really make substantive change, you really need to sort of change broadly the resources that are provided to organizations, change the rules around how organizations function, and then you can really make, I think, a more substantive change. So we sort of think about, we have all these skills as emergency physicians. So we have been called availabilists. So we are available. We can, we're sort of the jack of all trades, master of none. Someone comes in with pretty much anything, and we can sort of figure out what to do. So how do we sort of deploy some of these resources outside of the four walls of the hospital? How do we think about bringing the skills of emergency physicians into things like telehealth? Kaiser Permanente does a fantastic job of this. Currently, about 30% of their physician time is spent in telehealth, freestanding ED models. But the question is, sort of when we're thinking about all the great things we can do in public health, and screening in the ED, and all these things, and how to bring our skills out. The question is, where are the resources? And I think we've got some of the answers are about sort of moving payment models. And Dr. Asplund did a very nice editorial in Academic Emergency Medicine. This was about 10 years ago with a great title called Form Follows Finance. So if we can figure out how to either pay for things differently through different quality measures, different payment models, conditions of participation, really trying to utilize the levers that really sort of move mountains, I think we can really make a big impact. So next, I'm going to focus a little bit on payment and delivery reform and come back around to injury prevention. So we've all seen this curve. Costs are going way up. There's been tremendous push through the ACA, tried to expand health insurance coverage, alternative payment models. MACRA of 2015 pushed out MIPS, new quality and measurement programs. There's been the CMS Innovation Center is testing a whole bunch of new models. Some of those apply to emergency care. There's a lot happening in the private market where the goal is to, can we develop a more coordinated system, a more patient-centered system, and potentially, one that sort of thinks about the upstream as opposed to just the downstream. So trying to prevent things from happening in the first place, that's where sort of capitation is. So if you can deploy resources to a system, community, and say, look, you've got to go outside the four walls and start thinking about injury prevention, because if you don't do that, then you're going to be disincentivized. That's I think the way we should be thinking about it. So the election of 2016, things changed. Election of 2020, there are a lot of proposals being talked about that could potentially could really change payment in medical care. So the issue, so we're sitting in the emergency department. People want to change payment, but there are these issues we have. So, demand is somewhat exogenous to us. So bus crashes, we see them. There are these social determinants out there. So if there's a hurricane going on outside the emergency department, there's, in the community, there's usually a hurricane going on inside the emergency department. We don't have good data availability. We don't have, we play a critical role in the public health system that pretty much goes unreimbursed. We've got the unfunded mandate of EMTALA. And then you start thinking about, okay, so now you want to, so it's great to do injury prevention and sort of give little money here and there, but then you want to actually change how we're actually practicing and start reducing the intensity of what we do on top of that. Is this going to lead to medical errors? So this is how the federal government is sort of thinking about payment models now. This is sort of categories 1 to 4, so fee for service. Still, almost everything is here. We're sort of moving to paying for value, and specifically, this is about paying clinicians and hospitals differently if they deliver a higher quality product as measured by performance measures. And this is an area where I think injury prevention can come in. Is that there are several measures of things that we can do in the emergency department around NQF measures around alcohol and cigarette cessation. There are approved measures there. So I think for the injury prevention and community, trying to think about things that we can do where there's evidence that if we do something differently in the emergency department, how is that going to lead to really different downstream outcomes? So, and then when it comes to actual full sort of one-sided risk, specifically where if we do things, if we save a little bit of money, that's great. We can keep some of it, but if we don't save money, there's no downside risk. But this is really where we're going, is sort of to two-sided risk. So models where, like capitation, where either communities, hospitals, accountable care organizations are going to get a fixed amount of money to take care of a population, and that's where public health and injury prevention are really become more important, because if you can prevent injuries from happening in the first place, and you're receiving a capitated dollar, that can really benefit the finances of the system, and it becomes a much more there is a much greater return on investment, and these are the kind of terms that I think health systems think about. So what are some areas that we're currently thinking about for emergency medicine payment models? And things like admission rate variation, variation in CT utilization. We start thinking about how do we sort of pay differently if we admit more efficiently, use CTs more efficiently. If we deliver different quality care, specifically when it comes to performance measures. These could be process measures that are associated with better downstream outcomes. Again, here's the role for potential role for injury prevention measures, and also in shared savings. So some of the current reforms actually do not include injury prevention, but they could. So currently there's this acute unscheduled care model that has been approved by HHS. There was a letter about a month ago from Secretary Azar. This is a model where basically takes 4 conditions and says if you can reduce admission rates for these particular conditions, then you can get some shared savings in there. You can do telehealth visits. The HHS has not moved on this yet. I'm actually working on what's called the edict model, which is a very similar model in Maryland right now. We're actually pretty far along. We've expanded the acute unscheduled care model to 10 conditions. We've also focused on frequent users. This is going to be a shared savings and a telehealth model for Maryland hospitals if we can get this through. And then another area where I'm focused on is trying to figure out sort of a win-win with some of the private insurance companies, specifically looking at sort of a similar model of these sort of condition-specific variation, but also looking at variation in CT utilization. And what's interesting, having a lot of these conversations with payers, is that they're actually very interested in clinical quality measures. So they are very interested in narcotics and making sure that we're not prescribing narcotics. And interestingly, I had a conversation with a payer last week that, I showed them all our quality measures and said, we're interested in you prescribing less narcotics and really sort of driving this down, which is not necessarily about dollars. So again, when it comes to, these private groups and a lot of these payment models, thinking about taking sort of the injury prevention, using an injury prevention lens and trying to create some measures that that really sort of link injury prevention in the emergency department to improved outcomes later. So if we start screening for things in the emergency department, are we actually preventing later events? So I'm going to end with vision of an ideal system. We are certainly far from that. So, can we create and expand patient-centered ways to deliver acute care, improve the efficiency of the system, but specifically, how do we sort of prevent avoidable health problems and associated care from occurring? And a lot of that is sort of reaching upstream, but really the resources still today are in hospitals. And how do we get emergency departments and hospitals to move and actually do things differently? And I think we've got to think about these broader mechanisms of payment reform. And I think, again, this is something that we're already doing well, and I would say continue with the advocacy, continue to utilize our skills to advocate for our patients. So with that, I'll take any questions. Thank you. Okay.
Now that you've been in kind of both models, do you see any in the ideal system? Because like what an academic system kind of wants out of the ED is kind of different than what the community system, kind of the relationship between the ED and the hospital system, a little different. Do you see any conflict or, I guess, limitations in implementing these things with that company?
Yeah, what I've learned from spending years sort of in the innovation world is it's very hard because it depends, because everyone has a different perspective. But I think the more you can find common ground, I think the common ground that physicians and hospitals really want to focus on is better patient care, patient safety. So I think if you can sort of frame it around that, I think that you can really make a difference. I think in terms of academic versus community, it really sort of just depends upon the players involved. Seeing a lot of hospitals and a lot of health systems, they're sort of people who are collaborative everywhere, and it doesn't differentiate academic versus community.
Thanks. I have a quick question. Thanks, Jesse. That was great.
Yeah.
Dr. Cunningham presented data showing that pediatric patients who present to the ED with any interaction with violence have a high likelihood of coming back and having another interaction with firearm injuries. Do you see any way to sort of start to predict some of these injuries and get in front of that and make that sort of a quality measure?
Yes. So the question is, what is the individual provider to do differently, and how can that action lead to a better outcome later? I mean, that's ultimately the question that we've got to be answering, because everyone says, you got to ask about this, and this. Don't forget about this particular issue, whether it's HIV, hypertension, gun violence. But how do you get that clinician in the moment, one, to think about it, and to think about it, and two, to have a system built in place so they can't forget it.
Or you don't have the clinician be the one doing the action.
Yeah, or you have other resources.
We're a system, and physicians are, I'm sorry, I will long advocate, are not the ones doing most of this screening.
Yeah.
And I agree that there is a long laundry list of things that we're supposed to be screening for, and so part of it depends on where you're working. For the kids that we're taking care of Flint, for that particular population, their leading cause of death in the next 2 years will be from gun violence. So, I mean, you can't do everything for all people, but the opportunity to focus on where your community is, regardless of what that community is, and focus on the highest risk for that community, and or to tailor it. But it's a system. It's not often going to be the physician.
But I think it's. Yeah, I think it's having incentives to have those resources there. Yeah. Other questions? All right, thank you.